Good afternoon, everyone. I am Ali Fodi. I'm a program officer here at NYHealth in our primary care priority area, and I'm so pleased to welcome you today to our discussion. We are going to be joined by speakers with illustrious careers as legislators, as primary care clinicians, as policy advocates, and they'll be discussing with us policies to strengthen primary care and to improve the accessibility for all New Yorkers. While NYHealth is prohibited from supporting particular pieces of legislation with our lobbying restrictions, we felt like it was vital for us to create this forum for us all to learn together about emerging policy solutions coming here to New York that stand to bolster New York's strained primary care system, and in doing so, improve health for all. So in just one moment, I'm going to hand it over to our president and CEO, David Sandman, to introduce these illustrious speakers and to set the stage for our discussion. But before I do so, just a bit of housekeeping. There is closed captioning available, and you'll see that in an icon at the bottom of the screen. We will be recording today's session, and we'll send an event recap with that recording shortly after today's discussion. And lastly, please include your questions and your comments in the chat, and we will do our best to lift that up into our discussion. So with that, welcome again, and I'll hand it over to David.
And welcome to everybody. We've got a great crowd today. We had a little over 300 people registered for this webinar, so widespread interest from all corners of the state. And we've also got a great lineup of speakers for you today. On your screen, I want to start by welcoming Jordan Goldberg, the Director of Policy at the Primary Care Development Corporation, as well as Dr. Linda Clark, the President and CEO of Jordan Health, truly an amazing FQHC up in Rochester. And we are expecting two of New York State's top healthcare policymakers, Senator Gustavo Rivera and Assemblymember Amy Paulin, who each chair the health committees in their respective houses of the state legislature. This is a super busy time in Albany as the legislative session, I guess not really winds down, but races to a close. I think Jordan told me she was in Albany earlier this week, and I think Senator Rivera, who's joining us now, had like 11 events or more that very day. So it's a very busy time in the state. I'll welcome him in just a moment. Senator Rivera, are you here with us?
I am indeed. I have life.
Here you are.
life always intervenes. I have there's apparently a leak in my apartment building that might be coming from my apartment, but we weren't sure. So my super was sleuthing for a bunch of so I'm late because of that, and I'm not in my home partly because of that, because then I have to be someplace else afterwards and I couldn't get to my car. It's a whole thing. Good morning or good afternoon to all of you.
All right, well, welcome and good luck with the leak, whatever the source of that is. Like I said, we're expecting your colleague, Assemblymember Paulin, in just a little bit as well. So thank you for joining us, Senator. All right, it should be on everyone's mind that Mother's Day is right around the corner. It's on Sunday, don't forget. And the reason I say that is because I often refer to primary care as the mom and apple pie of healthcare. You know, everybody says that they love it, and rightly so. People who get primary care are far more likely to get crucial preventive care like cancer screenings and flu shots. People who get primary care exhibit better health outcomes. They absolutely exhibit better management of chronic diseases like diabetes and asthma. You know, and for people who care about money, and that's everybody, primary care also saves money. Better access to primary care is associated with fewer hospital visits, fewer emergency department visits, and fewer surgeries. So, you know, it's an obvious public good, and it's one of those rare win-wins in healthcare, you know, where we can deliver better care, better patient outcomes, and in fact, make better use of the dollars that we spend on healthcare. And those opportunities don't come along every single day. So despite what seems like such an easy thing to embrace, primary care does not get the love that it deserves. We chronically underinvest in primary care. It only gets like 5 cents, maybe 7 cents at most of every healthcare dollar. That's a pretty meager amount, if you ask me, for the best part of healthcare delivery. And, and the results of that underinvestment, are profound. A new report just put out by PCDC found, quite severe primary care workforce shortages. And, it's not one story. We see lots of variation across the state on things by region, by your insurance status, and by race and ethnicity. So we're going to spend this hour talking about potential policy solutions to that. So just to get things rolling, I'll kind of go around the circle and ask each of you. You each have a very different perspective and a different position. From where you sit, what's the biggest problems that are facing primary care? And I'll start with you, Senator Rivera, if you're not underwater.
Not at this moment, but hey, check in with me later when I get back home. So I guess my perspective is that there's certainly when I think about the healthcare system in the state of New York, or certainly the healthcare system that serves vulnerable New Yorkers, the lack of investment over time has been particularly concerning to me. And as it relates specifically to primary care, as you're certainly, we're going to talk about the numbers a whole bunch, and certainly you're going to talk about the scorecard that you folks just put out, which is precisely why I've introduced the bill, and I've been fighting for the bill to actually increase the amount of dollars, the percentage, and certainly the amount of dollars that we spent on primary care in our Medicaid population. If we do that, not only, and this is what's just particularly like head scratchy when we think about investments and lack of investment across the board. Putting more money into primary care means that people can identify chronic conditions earlier, means that people will lead better lives, which means that the system will be overall cheaper. So as I think you might have said this already, but it's a win-win-win all around. So from my perspective, the biggest problem is that we haven't actually, the biggest problem is that we have a healthcare system that has the profit motive at its core. But that's that's a much bigger problem that we're certainly trying to tackle. But for me, at least right now, that we're not spending enough money on primary care, that we're not spending enough of our dollars on it, and therefore having a system that produces our outcomes our outcomes could be better, and they could be more, and the system could be run more cost effectively.
As a senator, you've got a whole different bill addressing that profit motive, but we'll save that one for another day. All right, Dr. Clark. So, you are right there on the front lines, core safety net primary care provider. From where you sit, what are the biggest challenges?
I mean, I think you already said it. Workforce is a huge challenge. We can't attract physicians in primary care. I think the problems are reimbursement. The recognition, the prestige. To me, primary care physicians are the ultimate physicians, and they're not really viewed with that awe as our procedural driven specialists are. And certainly the money, the financial incentive to go into the primary care field is just not there. And then we're seeing it with our APPs as well, the advanced practice practitioners, PAs and nurse practitioners who want to go into the procedural fields, and they're getting paid more to do that. So we have to fix that. And then, along with that is the ability to retain the workforce that we have at all levels. I mean, we're competing with Costco and Burger King, for some of our most important staff, who are usually the people that you first see when they walk in the door. So in order to do all that, we got to get paid. Right. So the reimbursement is just not there, as you've already said. As a FQHC, as a safety net practice, I feel like we're feeling it even more. With over 70% of my patients on Medicaid, we haven't had a rebasing that payment since 1999. That's, I don't understand how nobody else does that. You can't go to Wegmans and get a cucumber for, now that what you could to do in 1999. And then just, as you mentioned before, this lack of foresight. My training is in preventive medicine and public health. So I was trained to play the long game. And nobody wants to play the long game. They want something fast. They want it now. We're a microwave society. Give it to me now. So we're not realizing the benefit of prevention at all levels. So that lack of foresight, this need for this glamorous and financially fruitful, not for me, but for others, the people that we treat who are very sick. That's where we're putting all our dollars, and not into prevention, which lives in the primary care realm.
Thank you. It wasn't lost on me that you mentioned Wegmans since you come from Rochester. I could have predicted that one. All right, so Jordan, you're in a very different part of this ecosystem, not an elected official, not a provider, but analyst, expert, advocate. How do things look from your perspective?
Thanks. I mean, I'm really glad to hear what Senator Rivera and Dr. Clark said, because it is exactly what I was going to say. From the policy perspective, the lack of investment in primary care is one of the core problems affecting access to quality primary care in the United States, not just in New York, but across the board. People should have access to quality, affordable primary care in their own communities. That's how we will get closer to health equity. That's how we will improve people's health, so that they don't end up in the hospital with a severe chronic condition, so that we have a lot of avoidable severe health conditions that happen because people can't afford care or don't have access to it. As you said, primary care makes up about 35% of health visits in this country. It only gets about 5 to 7% of that healthcare dollar. And the lack of adequate funding is impacting both patients and providers. We think a lot about providers when we think about the funding, but when you talk about having people to go see, for those patients to have someone go see, there's inadequate access, there's low quality care, there's poor health outcomes. And one of the things that hasn't come up yet is just the overburdened workforce. People who are sticking with it, who are willing to provide primary care despite the lack of funding, they're really burnt out. And the administrative burdens that they face, because we put so much on primary care, because it is such a great source of prevention and because it's such an important part of care coordination, they have so much administrative burden. So it loses professionals that are experienced, and we have trouble attracting new ones to the field. If we invested more, we could sort of soothe a lot of those problems. And that's why we're thrilled that Senator Rivera has introduced the legislation he has.
Well, thank you. And we're going to go a lot deeper on the investment topic and the Primary Care Investment Act. I'm going to save that until Assemblymember Paulin joins us in just a few. So instead, I want to take up the equity angle. It's not an afterthought. It should probably be very prominent in these discussions. On virtually every single measure in healthcare, whether it's a process measure, a care delivery measure, certainly an outcome metric, we often see, big disparities, by race and ethnicity, where people and communities of color almost always end up, on the short end of the stick. So I'll start with you, Dr. Clark. If we had a more primary care centric system, what could that do for New Yorkers of color and other marginalized communities?
Yeah, no, thank you for that question. Again, prevention is the keystone, of primary care, and that's what is going to pay. That's what's going to get us to equity. However, we have to be in a system that we trust. And, Black people and other people of color, as you mentioned, have traditionally had much poorer outcomes for many conditions, including, breast cancer, diabetes, hypertension, colon cancer, prostate cancer, on and on and on. We can name them. And prevention, is the key, but it's multifactorial. And, so preventive care by primary care providers is so instrumental, but you have to get the patient in the door. And when you ask about primary care centric systems, they're basically patient care, patient-centered ones. So if you can assess and connect people early to not only medical assessments, but the social supports that impact health, that is often done within the primary care realm. So primary prevention like immunizations and lifestyle management, they can and they should be done in the primary care offices, but they need to be reflective of the community. We need to make sure that we have people of color who are available and treating people of color and have that cultural brokerage to be able to do that. We need to have more conversations, more precision medicine with our patients to come to decisions about care and early detection of things like, cancer. And that could exist right in the community health centers and not just in boutique practices. So patient-centered systems will definitely address and handle discriminatory practices, which still exist. We're not going to put blinders on, they still exist. But in turn, if we can address that, we will get to the roots of that distrust that is understandably, a factor in truly accessing primary care. Just because your door is open doesn't mean that everybody will walk through it.
And of course, a very warm welcome to Assemblywoman Paulin, who just joined us just exactly on time, as she told us that she would. They are juggling hyper busy schedules in Albany these days. Well, welcome, Assembly Member. You're right on time. We're going to get in just a moment to talking about the Primary Care Investment Act, but we're talking now about health racial equity. So I wanted to give you the same question, Senator Rivera. You're proud Latino, you represent many people of color, you've championed equity, across dimensions, whether it's health, housing, criminal justice, your voice has been very loud and consistent on equity. Tell us, how does a better, more primary care centered system, how would that contribute to racial equity in New York?
Certainly go a long way. I mean, we're talking, part of the problem with the health inequities that exists in healthcare is that because they're intergenerational, they're going to take generations to fix. And that's always, I think one of the panelists earlier talked about, I think it was Dr. Clark, who spoke about the fact that sometimes we want things to be solved immediately. And so we care about the things that we can see right now. And longer term solutions are usually, they're kind of pushed to the side because they obviously take longer term investment and we don't see a result immediately. So going towards fixing our problem with access to primary care would certainly go an enormous way into right sizing, to try to get better as far as health inequities go, but it'll take a long time to do it. Again, when Dr. Clark talked about places like the Bronx, the high rates of obesity, heart disease, hypertension, et cetera, et cetera, et cetera. Those are things that they don't happen overnight, right? They are intergenerational. They have to do with, there are a bunch of social and economic impacts on that, and changing those social and economic, indices, if you will, is also something that takes a long time. So just on the healthcare side, just making access to primary care more accessible and put more investment there is going to be one of the things that helps us do that. But again, we have to look at it longitudinally. We have to know that it's going to take a long time to fix, and we have to be committed to it, knowing that these investments do work. Because again, those disparities point to certain communities which have access to healthcare all the time, are in better socioeconomic conditions, and the outcomes there, when you compare them to poor working class neighborhoods, certainly the Bronx that I represent, that's what we're trying to strive for, and so we know what those numbers can be. We just have to change the conditions over here, and that always takes a long time to do.
Hear you. I bet you often tell people, look, if it was easy and quick, it would have been done. Okay. All right. Well, look, we are fortunate to have possibly the two most important healthcare decision makers in New York State with us today. And both of you, are the lead sponsors in your houses of the Primary Care Investment Act. So tell us about the bill. Tell us, what it would do, how it works, and tell us why you're so enthusiastic and championing this bill in the legislature. Maybe I'll start with you, Assemblywoman Paulin, since you've just joined.
So for all the reasons that my great colleague in the Senate said, it's very critically important that everybody has access to primary care. It's we say it saves money as somehow the excuse to promote it, when the reality is it makes our lives better every day. So it's only fair and right that everyone has the same access and availability for those things that is going to make their life better. Gustavo and I like to say, healthcare is not a luxury, it's a right, and that starts with primary care. So what does the bill do? The bill recognizes that I'm not going to say we need a stick. I'm gonna say we because the bill is really about incentives to help guide us or help bring us to the point where more people are getting primary care. It recognizes that there should be a certain amount of healthcare out there that is for primary care. And we don't really know what those numbers are. We don't know per plan or per health plan, which is what we're asking for the reporting mechanism to be, what they're doing. Are they effectively, remember, managed care was supposed to be about managing care, helping people get to a point where they were using primary care a lot more. And we don't know if that's what our health plans are providing people. Are they giving them those tools that they need? Are they bringing people to the right providers? So it requires reporting on their part. So we will have a sense, is one health plan better than another in doing that? Do they, is it a population? Is everyone in the city getting poor care? Look at the demographics. Is everyone upstate getting poor care? We don't know until we get that reporting done. And then it says, and they have to, and it's required that 12.5% are again, of their clients or their healthcare is got to be on primary care. So that's really what the bill does, and it allows for some incentives, quality incentives. If a plan gets to that point. So it's a combo of reporting, the requirement of the percentage, and then some of the incentives to encourage and to maintain that. And it's I'm even thinking we might need a stick in that bill, if we don't get it this year. So I'm thinking about the appropriate sticks. So but that's essentially what the bill does. And other states have done similar things, maybe not exactly to what New York has done, but I think it's about 10 or 12 states have already set a percentage and already have asked or required health to go in that direction, and New York should not be behind that.
Okay, thank you. So I'm going to try to unpack, you said a lot, I'm trying to unpack it a little bit, and I hope you and the senator will tag team on this. So it sounded to my ears like there's at least 3 components to the bill, and the starting point is measurement and reporting, right? Like, we don't really know with precision how much of our healthcare spend is going to primary care. We've got awfully good guesses. We see a lot of national measures and so on, and that tells us it's about somewhere between 5 and 7%. But the first part is to establish a genuine baseline measurement of primary care spending in New York. Is that right? Okay. And then from wherever we're at that baseline, let's just say it's 5% for argument's sake, it would eventually move that percentage up to 12.5%. Is that right? That's right. Okay, so that's a big increase, right? I mean, 12.5 is still a relatively modest portion of our healthcare spending, but it would be more than doubling what we spend today. So it's a pretty significant move over time in the right direction. I think you're on mute now, but I see you smiling and thumbing
I
up.
know I'm on mute. I know I'm on mute, which is why I'm doing this. There's like a whole speak about healthcare, the healthcare plans. There's a healthcare plan with a loud ass radio station right downstairs in front of me. So I just keep it on mute so you're not hearing the bad bachata coming through. That's why I'm like, I have it on mute. So yes, I'm doing this for this. That's how you know.
And is this for both of you, is this an all-payer approach? This would apply to our private insurers, to Medicaid, you know, everybody, right? Yep, okay. I think I saw heads nodding. Yes. But and how do we get from here to there? Is this a gradual phase-in process?
Well, we passed it in the Senate. I'm certainly hoping that my colleague, and one of the things I'll say about this, Amy, because Amy and I have been, she's the newish chair of the health committee. She's only there for a couple of years, but one of the things that I'm very thankful is that if there's anybody that knows the assembly, it is Amy. So if there's somebody that can figure out how to get things done over there, it is her. So I'm hoping that can happen. Then we have to obviously get the governor to sign it, and then in its implementation, the goal would be to have like a 1%. Like once, as Amy said, we need to define, we need to measure, we need to report so that we know where we are and we know how to where we need to go. But we're looking at maybe like a 1% increase each year, so until we get to 12.5, that would be the goal.
Okay, so it is a gradual phase in, a year by year 1% increase, which I assume is designed, you know, to not be disruptive and, you know, try to change everything overnight. Like you said earlier in this session, you know, change does take time, but it would consistently move us in a new direction every single year. Is that correct?
That would be the goal, sir.
Okay. And you started to hit to this. If I could ask each of you, what's the status of the bill in the Senate and in the Assembly?
Passed in the Senate.
Passed in the Senate. Well, congratulations. And Assemblymember Paulin, you are, if nothing else, you are a very prolific legislator. You've passed so many bills in your time. Where does this one stand?
I don't expect to be able to pass it, honestly. The Assembly is caught up on the 12.5%, you know, and they're willing to do reporting to get a benchmark, but they seem inflexible on establishing that 12.5. And since I know that the advocates don't want us to pass it that way, you know, I'm not going to make the amendments.
Right. And is
By
there
the way,
something?
I should. I'm sorry. We did get it out of my committee, so it's now in finance. I should be clear about this. We passed it out of my committee, which is something we hadn't been able to do before. So that's a step forward. And we're finding some of the same resistance that Amy was talking about, but we're working on it.
And the thing is, it's not in my committee. You know, I have less control. It's in the insurance committee.
Is there something at the heart of that objection, or is it just that, you know,
I just asked where it came from. You know, why did we pick 12.5? You know, now there's lots of reasons to go with 12.5. I mean, you could argue that you can even go up to 15. But there's a lot of pushback, and because it's uncertain, and I think the insurance companies are, because there's no data out there, everybody is leery and nervous about the 12.5. So I think we have to do a lot more convincing that that's the right number. And honestly, we're not going to be able to do that in time for this session. Not that I can tell. You know, pushed very
As,
hard.
and as far as insurance companies, if I told you that they're my favorite,
You might have told me that a few times.
Yeah.
Jordan, I
favorite.
think you have a lot to add to this and put all of this into a broader context because New York State is far from alone in trying to rebalance its health system towards primary care. I mean, the reality is, we're so far from a leader, we're actually lagging behind, dozens of states at this point. So, give us the history. How this whole movement for primary care investment get started, or what does the national picture look like?
Sure. And thank you, both Assemblymember Paulin and Senator Rivera, for giving us your candid assessment of where we are with this. As we know, policy change takes time. Policy change that involves money takes longer. And we're absolutely committed to getting to where we need to be with this, even if we need to educate a lot more people about why primary care investment is so important, which we will do. So the lack of primary care investment has been recognized by experts for quite a while, and efforts to address the problem have began many, many years ago. But it's probably the first specific policy that's similar to this one was adopted by Rhode Island in 2009. So at the time, there was an Office of a Health Commissioner there, Health Insurance Commissioner, and they essentially were able on their own to say, we don't think we're spending enough on primary care. We're going to require commercial insurers to increase their spending 1% year over year until they get to, a better percentage of their total spending. I want us to talk a little bit about that 12% number. So it feels, when you look at this bill or what many other states have done, to be arbitrary, but it's not. We spend as the U.S. roughly 5 to 7%. We're not sure exactly state by state, but that's about what we're spending. When you look at other similarly situated countries, in Europe and Canada, places that have honestly far better health outcomes than we do, far better health performing systems than we do, they're spending at least twice that, 12 to 14%. And that is what the World Health Organization has said is about what you should be trying to spend. They actually say you should get there and then you should keep going 1% above until you're spending a good chunk of your health dollars on that foundational primary care. So since Rhode Island took that first step, at least 16 other states have started to take steps towards increasing spending on primary care with, a couple different approaches. Some states have started just by measuring or by setting up a task force to do that measurement and then make recommendations about what that increase should be. A few states have directly required insurers, both public and private, as the Assemblymember and Senator's bill would do, to start that increase 1%, usually 1% each year, till they get to 10 or 12% with accountability and reporting. We're starting to see federal policy move in this direction too. We've seen the Biden administration, the Centers for Medicare and Medicaid Services have released both statements and new programs that are centering primary care and trying to rebalance the health system towards primary care, all with the idea of setting a target, because if we don't set a target, it seems that insurers are not willing to make that change on their own, even though most stakeholders in the field recognize that if you put the money in on the front end and keep people healthy, you will both save money in the long run, but also people's lives will be better, as the Assemblymember Paulin said, which I think is exactly right. Primary care has the potential to make people's day-to-day lives better, their communities healthier, kids in school, people at work, and save money over time. So a lot of other states are doing this. New York is by no means the first. It would be right in the middle of the pack if we get this done in the next year or two.
I don't want to say do you have a favorite, Jordan, but among all those states who are taking action, are there some that you think are particularly relevant or good models for New York to base our own work on?
It's an interesting question. I think there's a lot of interesting work going on in this space. I think that I would point to both Oregon and Connecticut. So in Oregon, what I think is really interesting about their model is that their reporting is by insurer. And so it wasn't the first couple of years people could aggregate, but now at this point, they publish every year exactly how much every insurer is spending on primary care, and they have a hard target that they have to meet. So that sort of accountability and transparency helps everyone in the health system see what's happening and hold those plans to account. And then in Connecticut, what I appreciated is that they added this to a more general cost growth benchmarking process where they said, we want our whole health system to be better. And we think the way to get there is to put more funding into primary care. And they put out both an executive order and a law, both to set a hard target. And they did that over the course of 1 year. So they're just swiftly trying to move their system. And I think that's a good model too.
So this is for the senator and assembly member. It feels like things in New York are a little bit circular. If memory serves, the New York State Legislature already passed a bill a few years ago that would have established a commission to do that measurement and reporting part. And I think most people thought that was going to proceed. It was something of a surprising veto by the governor of that bill as part of a much more sweeping veto, where the executive chamber said, we're not really into all these commissions and task forces. And we already know that we spend too little on primary care. We don't need to spend a lot of time, establishing what we already know. Maybe we should be moving towards action. Hence, why don't we set spending targets and so on? So where are we in this circular dynamic of we already know and we're ready to jump to action, or we need to go back to the same kind of bills that the legislature has already passed?
I'm sorry, ask that last part again. You broke up over here.
Yeah, me too.
It just feels a little circular to me, like the legislature a couple of years ago already passed a bill to
Right.
do the measurement and reporting part. That had a surprising veto, in part saying, well, we already know that we spend too little on primary care. Maybe we need to move towards action. And thus you have introduced a new bill that skips the commission and says, yeah, let's do it. Let's start spending targets and moving in that direction with action. But then I thought I heard you saying, assembly member, there's some hesitancy, like, well, maybe we're not quite ready for prime time. Maybe we should do the measurement and reporting.
Well, I don't think that we do it per plan. I don't know what that other bill looked like because that predates when I was health chair.
Well, that was the senator's bill. So
yeah, so I'm not familiar with the veto or the bill. So I don't know how identical that reporting requirement is to the one in the bill. I think the way this bill that we have together is structured, it would generate specific information per plan. So I was leaning toward encouraging you to take the amended version so that we had something. But I get the desire to have to, not to be lagging behind other states who are already being much more aggressive. My feeling is, now that I'm aware of that veto message, I'm going to take a look. Maybe you can even help me by pointing me in that direction. But to see whether or not there's people in the administration that we can have a direct conversation with, because obviously they're not doing it, even though they know that, and they may need a law like ours in order to do it, right? But maybe not, but they're not doing it. So if they already are aware, what are they doing toward that goal? And, are they setting a target like we did in our bill? All of that would need to occur in order to really be effective. So I'm very curious about that other bill. I'm assuming Dick had it. And just to see what that veto message looks like and what that bill looked like, in order to know what the next steps should be.
I'll move on, unless Senator, that was your bill. So did
Well,
you
just very quickly, as far as vetoes are concerned, like basically I'm this emoji, the shrugging shoulders emoji, because I trying to figure out some vetoes sometimes is just I don't get. There's many of these that I do not get. So I'd have to go back and look at it and see if we got a straight answer. The likelihood that we did is not very high, because many times we make the changes that they asked for and then they veto it again. So
100%.
I'm going to steer us away from the politics and more back to
and also, was it the same governor? That also I don't know. That also. I've had success sometimes by waiting out the governor.
That as I know, it was Governor Hochul.
It was,
But
okay.
anyway, to move back to
Yeah.
the policy side
Yeah.
of things, this is a question for anybody, Jordan, anybody on the panel. Again, in the spirit of how do you get from A to B, you know, how do we actually increase the primary care proportion? I assume that enhanced reimbursement rates is one way, but not the only way you can progress towards that 12.5% target. Is that right, Jordan?
Yeah, absolutely. And I would be interested in, hearing from Dr. Clark about how she would like to see more investment happen in the clinic setting. I would say from our perspective, from the policy perspective, there's a lot of places where those funds should be spent. And we're not just talking about reimbursement rates, but we are talking also about reimbursement rates, both for physicians and for other practitioners. There's a real need when you think about the Medicaid population, so the people in our state who are lowest income, who really need wraparound services, who are likely to be the most vulnerable and have the worst outcomes, those rates need to be high enough to incentivize providers to want to take Medicaid insurance patients. And that is not always the case in New York or in a lot of states. But I do actually want to defer to Dr. Clark and hear a little bit about what you think it would make a difference in your clinic.
Yeah, everything makes a difference. As a FQHC, as I mentioned before, I always remember the year my daughter was born in 1999. She's about to turn 25. It was the last time our payments were rebased. We're asked to do more and more and more without anything to support that. Chicane's had a study commissioned with the Urban Institute. And, it showed that we have 30% of our costs not covered. That's just not sustainable. And we are the safety net. We do want Medicaid patients. We want to be able to take care of these people, and we do it with skill, and we do it with high quality. But how long can we do that, with this lack of reimbursement on our backs? It's not sustainable. And I think, my colleague Neil Coleman said in the chat, it's an emergency. We need something right now. Okay. It's nice to study and look at this and that, but we've done some studies. We know we don't have enough money to take care of people, and we know that primary care pays. So it's time to make a move. And if you want to start someplace, you can start with the safety net. You can start in the FQHC, where you can really see those dollars go a long way. But I will yield, but I can't say it any other way. Something has to be done soon.
Well, I'm gonna come back to you, but I want to also, and I know we might lose our electeds a little bit early. So first, I just want to make sure I'm clear on one point with both of you. The Primary Care Investment Act is not about necessarily spending more money. New York State spends a lot of money on healthcare. It's really about shifting and rebalancing how we spend our healthcare dollars, right? To spend them in a different way, a smarter way, a way that provides more value for those dollars. Is that correct?
Absolutely. I mean, from my perspective as well. I mean, I'm sure you're asking the the advocates, but absolutely.
Okay. Like I said, I know that you have really hectic days. We're so grateful for the time you've spent with us today. So I want to give both of you, Assemblymember and Senator, last comments or thoughts that you want to share. I think you've got a very large and enthusiastic audience today. What do you want them to know before you've got to say goodbye for today?
I'll just say for myself, I just want you to know I really appreciate your advocacy and opening my eyes as a relatively new chair, actually only a year and a couple of months, to this whole push to get more primary care. I think it's critically important, and I want you to know I'm with you in trying to achieve that. So it's if not this year, we'll get it next year, and we'll figure out the way to get New York State to focus on this appropriately.
And I would say that for me, just to reiterate something I was saying a little earlier, we're not talking about more spending, we're talking about realigning that spending. And as we said earlier, that realignment will ultimately lead to a cheaper system, because it means that people are getting taken care of earlier, and they're the conditions that would require them to, that are when someone is not sick, that we'd have to spend on them, and giving them access to primary care means that we can actually keep them healthier. So what I would say is that this is, I mean, just commit to this being a long-term goal. There's certain things that we can do between now and then, certainly as far as the funding, and Neil and I have talked about this for years. We have been absolutely, I've been on the warpath on this for many, many years, as it relates to Medicaid spending, because I do believe that it's completely nonsensical to me that we keep making cuts to a system that serves the most vulnerable, who are the most needy, and we make these institutions then come to us on hands and knees, when they've been underfunded for a long time, and they're going like, could you please save us, because you're not giving us enough money to survive on a day-to-day basis. So we have to be better at thinking long term, and spending more on primary care is a very, very big important part of that, to be able to solve issues in the long term.
Okay, well, I want to thank you both, of course, for joining us today and your time at a busy time of year, but of course, an even bigger thank you for your leadership on this and so many issues in the healthcare space. We're very grateful for all of that.
Yeah.
Dr. Clark.
So I'm off. Send good prayers for my apartment leak, and I'll talk to y'all soon.
We'll send a lifeboat if necessary. So Dr. Clark, let's get out of Albany. We're out of Albany. We are back in the real world. Bring us back down to earth. What is it like running a super busy safety net clinic, day in and day out?
Yeah.
And we know that it's hard. Let's be positive. Tell me about the joys and the rewards of doing that.
I'll tell you about both. So, I mean, honestly, mostly it is joyful, right? To take care of people who are truly appreciative, and have needs. I think, all the joy that we have in working with the extremely skilled and smart and humble clinicians and other staff, that brings me great joy, and great pride. Honestly, I don't think anybody does it better than we do, frankly, and our fellow FQHCs. But it's frustrating, right? It's frustrating, the lack of resources, and especially when we see them enjoyed by larger health systems and in town. And now we're competing. We're competing with them to provide good primary care for the most under-resourced people. This is something new, for us. We used to, they used to love to send them to Jordan. But now with, other little incentives with dollars attached, we're competing, and we're competing for our patients, but we're also competing for the same provider pool. We talked about the lack of primary care. It's hard for a little FQHC to pay what they can get at the big systems in town. Medicaid is over 70% of the people that we see. So we really depend on, the 1115 waiver and other incentive programs, whatnot, that come through. And now we're jockeying for that. And that is something different. And I think, every day there's this little bit of anxiety about what's going to be pulled from, which rug is going to be pulled from under us, this time. Sometimes I say, does New York State not like us? The 340B debacle last year, that clawback on money that we had. Now, gratefully, they're trying to make us whole along with, with the federal reimbursement, but that's scary. I don't know when that's going to change. These Medicaid takebacks that we're paying back now. We're paying back money to Medicaid that they didn't ask us for earlier. That's every day something different. And our patients deserve beautiful, well-appointed spaces and what they may be getting in other offices, when they're getting just as good care or better in our center, but the appearance that the quality is different because we don't have a lot of money to throw around is concerning. But then down to the technology, we would really like all the bells and whistles in our EMR. They're quite expensive. We serve 22 to 23,000 patients, and we still, scramble to, make sure that we have the data that we need. And yes, somebody did ask about value-based care. We're involved with our IPA and some in value-based arrange and payments. And a lot of this, we need the technology to support what we're doing around population health. So I can go on, but I got to tell you, it is a joy, to represent Jordan Health because we do a fantastic job for our patients, and they know it.
Thank you. Time is running short. There's a lot of good questions and comments in the chat, so I'm going to try to squeeze in a couple more before we need to say goodbye. Starting with the most basic one of all that's popped up in the chat. How do we define primary care? How do we define primary care spending? I know there is no single uniform national definition as yet. There's a federal agency who's working on that, and I think people will adopt it. But in the meanwhile, are we all talking about the same thing when we say primary care? You want to take that one, Jordan?
Sure. And then Dr. Clark, if you want to add to it, I think the question of how we define it is a big one, and it's one that has been grappled with across the country. I would say that the national group, that's the federal group that's trying to come up with a definition, surveyed and found that in 20 states, there were 44 different definitions in use right now. So there's no one answer, even in one state. But I would say the thing that's most important to us is that we're talking about team-based comprehensive care that meets patients' needs over time, that's coordinated, where it's their first point of contact and that coordinates them as they go back and forth with specialists. We are concerned with who's providing the care. There's physicians, there's PAs, there's NPs, but there's also the care team around that person. So we want to make sure whatever funding we're defining is paying for that team-based care and not just paying fee for service for that physician or that PA or that NP. And that the range of services that we're talking about are the range that people need throughout their lives. And that should include behavioral health that often is provided by primary care providers. A lot of reproductive health care is provided by primary care providers. So a definition should include those things and be comprehensive. You want something that really reflects what it is like to provide primary care in the most comprehensive way. And Dr. Clark, I don't know if you have something to add to that.
No, I was going to say no, then I start talking. Your definition is spot on, and but it's I always use the word prevention because it's every aspect of prevention, whether it's primary, secondary, or tertiary prevention. So that primary, those immunizations, let's prevent a disease before it happens. Secondary, that early screening. And then tertiary, let's take care of a problem once you have it to mitigate it. I'm using that lens, and but no, everything you said, Jordan, I think is right on, and it's comprehensive and it's hard, and that's why it needs to be reimbursed at a better rate.
I'm going to squeeze in one more from the chat. I'm going to weave it all together. There's a lot of stuff going on in the world, right? We have a newly approved Medicaid waiver. We've got all of these federal demonstrations, making care primary, the HEAD model, which we anticipate New York to participate in, some questions about value-based payment. How does the Primary Care Investment Act fit with all those other things that are swirling in the air?
I will start with that, and that's a great question. I think that this bill that Senator Rivera and Assemblymember Paulin are carrying is actually really important for this moment. When we do have all these swirling policies, the federal government is pushing New York to invest more in primary care through these models that they're doing. Other states are doing the same thing. The reason this bill makes sense is it wraps around all of the policies that exist to try to push all payers in the same direction. The federal government actually only has certain levers to use. They can only really affect Medicare. and then through the waiver, which they negotiated with the state, some Medicaid policy. But if we did the Primary Care Investment Act, we would get to all payers at the same time. And when we think about primary care, we often talk about money, but when I think about it, I think about the patients on the other side of that. So that means whether you have insurance through your employer or your insurance through Medicaid or your insurance through Medicare, you would get access to higher quality primary care in your community, regardless of your source of insurance. So that's, I think, one of the good things about this bill.
Well, that's a beautiful place to wrap. I could easily talk with you all day on this topic, but there is legislation to pass and there are patients to serve. So we are going to have to leave it here for today. To the audience, there's always a lot going on at the New York Health Foundation. Thanks for joining us today. I'd encourage you all to visit our website at nyhealthfoundation.org, join the mailing list, and or follow us on X and on LinkedIn. That way you'll always be in the know and never miss any of these great events. Of course, my deep thanks to you, Dr. Clark, and you, Jordan, as well as our electeds, for the time they spent with us today. Thank you all for joining us. Let's keep moving forward together. I'm going to turn it back to you, Allie, for any last minute wrap up.
David, I would just echo what you said. There was so much good discussion in the chat, and I would say the best way that we can keep sharing more information is to stay connected with us. Chances are what we'll do is then keep connecting you with our partners, the policy experts and the primary care providers on the ground to lend their insight. So we look forward to having future discussions like this, and thank you all for joining us today.
Happy Mother's Day, and God bless all of our primary care providers. Thank you.
Thank you all.